Hi, I'm Bridget Hartman DeCenzo. Welcome to Learning Thursdays. A goal of Learning Thursdays is to support and help advance the educational and professional competency development of the prevention, treatment, and recovery workforce. A competency being comprised of knowledge, skills, and attitudes relative to a task. In part, we do this by offering monthly presentations that highlight content and topic areas that are current and relevant. Our presentation today is part of the Year of Ethics series and is entitled Person-Centered Language, Treating the Disease versus Responding to the Person. Our presenter is Maria Passeri, Director of State-Operated Addiction Treatment Centers. As always, if you have any questions, please feel free to contact us using the Learning Thursdays mailbox. And now we will begin our presentation.
Hello, everyone. Welcome to Learning Thursdays. Today's topic in the Year of Ethics is person-centered language, treating the disease versus responding to the person. I wanted to spend just a few moments talking about the title because as we progress in this training, I want to make sure that you understand that when we talk about treating the disease, we're talking about a person with a substance use disorder and not using language to describe the person as their disease. So I wanted to make that point up front before we got started in this particular training. I also want to say that our field has changed dramatically over the past 5 years. And we have gotten used to long ago saying to the patient that they can't run their own treatment, that they have to surrender. And so what we're going to approach with this topic is that person-centered language, person-centered approach in therapy has to do with empowering the individual. So we're kind of switching up the paradigm at this point, and I'm hoping that you will understand the differences between those two concepts. So we'll get started with the goals of the presentation. First and foremost, we want to understand that communication with clients should be carried out in a manner that is in a professional tone and content, that it's not intrusive, and it's appropriate to the type of therapy and treatment. We also need to make sure that it's culturally sensitive and it's understandable by the patient. We also want to include today is a definition and the foundations of person-centered therapy and approaches. We want to be able to recognize and practice strength-based approaches when communicating with our patients or clients. We also want to include planning as a part of this presentation. So we want to understand the process and the important considerations of person-centered treatment planning and the utilization of SNAPs. And we will talk about what that means, but it does include strengths, needs, abilities, and preferences. And last but not least, we want to be aware of the New York State Justice Center Code of Conduct that was revised in January 2016 and ensure that providers are reviewing and citing the attestation annually. So, what is person-centered care? It's really a collaborative process between the person and his or her supporters. That collaborative process helps develop the therapeutic alliance, and it helps in the development and implementation of the action plan or the treatment plan that will help our patients or clients achieve his or her goals in their journey of recovery. The collaboration must have specific points, and so want to be able to explain that to you. First, it has to be oriented towards promoting recovery rather than minimizing the illness. So we want to keep it on the road of making progress and less emphasis on the actual disease or illness. It should be in the person's own unique goals and aspirations. It's important now, as I said before, that we want the person to be empowered to take on their recovery and have it personalized so that they can make it meaningful for themselves. They also articulate the person's own role and the role of both paid and natural supports in assisting the person to achieving his or her own goals. And so when we talk about paid and natural supports, paid supports could be peers, paid supports could be even the counselor can take a supporting and role in this case. But natural supports are those in the community. Could be family members, could be a pastor or a priest, it could be the person's landlord. Those individuals which help support our patients' recovery. It also should build on the person's capacities, strengths, and interests. We want to emphasize the use of the natural community settings for all services, consistent with the level of care that they're in. So we want to be able to begin that integration into the community with those supports, as I talked about. And the other thing, which is sometimes hard to handle, is allowing for uncertainty and setbacks and disagreements. These are helpful to the patient. They help them have a greater self-determination in terms of their recovery. Want to remember that, and as we have changed in providing the services that we do, that discharging a patient is not an opportunity for learning necessarily. We can take that situation sometimes and make it a teachable moment, make it a moment for that person to learn by their setback or their disagreement with you or the program. So why is it important to be doing person-centered care? It really is, in all the literature, telling us that it's a key component in developing high-quality health care. And research has shown that person-centered care can bring and have a big impact on the client's health outcomes. And so what do I mean by outcomes? Really, we want to get to know the client as a person. We want to recognize their individuality. As we develop our programs, we oftentimes have people going through the same types of programming. However, we have to be mindful that they have all come from different walks of life and that individuality is really important. And important for that person to make an engagement to your program. If they feel like everyone else, then they are not going to personalize their recovery. Seeing that the client is knowledgeable about their health and care. Also sharing the power of responsibility, that it's not all on the counselor, that it's a shared responsibility of things that the client has to do and things that the counselor and the program is doing. We also want to take a holistic approach in assessing a person's needs and providing care. That holistic approach is critical when we're doing integrated care. We need to make sure that we are also recognizing if there's any mental health issues or medical issues that the individual has along with their substance use disorder. And we also want to include families where appropriate. Families today have taken on a very strong role in their family members' recovery. We are working with a younger population, a population that necessarily hasn't left the home that they grew up in, and families are concerned and want to be a part of the care, as well as the individual wants to be connected back with their family. We also want to make sure that services are accessible and flexible and easy to navigate. We need to begin to loosen up some of our structures to provide flexibility to deal with the individual differences as individuals begin to enter our programs and engage in our programs. We want to look at people's whole experience of care to promote coordination and continuity. We also want to make sure that there's the physical, cultural, psychosocial environment of health services that support person-centered care. And we also want to make sure that staff are supportive, well-trained in communication, striving to put people at the center of the care. So, when we take a look at all of it, the person-centered therapy provides patients with an opportunity to develop a sense of self where they can realize how their attitudes, feelings, and behaviors are negatively affecting their interactions with others, so they can begin to accept. There are some core conditions to person-centered care, and we have to go back to our counseling roots, Carl Rogers, who really initiated this level of therapy that we utilize today. And he asserts that the most important factor of successful therapy is the relational climate created by the therapist's attitude towards their client. And so our attitudes also sometimes reflect how we behave with our patients. And that's where that interplay happens with ethics. So first, congruence, the willingness to transparently relate to clients without hiding behind a professional or personal facade. So we want to be genuine. That's that genuineness that Carl Rogers talks about, because our patients can see who we are, and we want to make sure that we genuinely connect with them. Also, we want to have unconditional positive regard. The therapist offers an acceptance of the client for who he or she is. We don't want to show any disapproving feelings. We also do not want to be biased in any way based on how the person is presenting to us. And we have to demonstrate a willingness to attentively listen without interruption and providing any kind of judgment or giving advice. And that's a critical factor when we have counselors who are first in the field. We're oftentimes so worried about what we're going to say that we're not really listening to the patient. And so listening is an important factor in how our verbal and nonverbal behaviors sometimes convey some communication that we don't necessarily want, or that we didn't intend to convey. And the other piece that Rogers talks about is empathy. The therapist communicates their desire and to understand and appreciate the client's perspective. And while we may not agree with their perspective, we need to understand where it's coming from, because this also works along with motivational interviewing, meeting the client where they're at, and reducing that resistance so that we can begin to decrease ambiguity. Now that we've discussed person-centered definition and the foundations that are inclusive of person-centered therapy, I'd like to move into the role of communication in the therapeutic setting. Communication is critical. It also is an indication sometimes of our attitudes, as we've talked about in previous slides. And it's important that we be able to communicate in a professional, non-intrusive tone with our patients or clients. It's important that the healthcare professional must consider the therapeutic implications of language used in communicating with our clients and families. And so we need to ask ourselves, how will the proposed language be perceived or experienced by the client or the family? What kind of message are we communicating? And not only is our verbal communication important, our nonverbal communication is critical when we're communicating, because there has to be some congruence with that. Would it be considered disrespectful, insensitive, or intrusive? And so those are some of the questions we need to ask ourselves when we're dealing with sensitive issues with our clients and or family members. Want to be able to provide you some guidelines for appropriate use of language. First one is avoid unnecessary jargon. Sometimes people use jargon to impress the patient of their knowledge. Sometimes that also pushes that person one step away because they don't necessarily understand. They might not ask because they don't want to feel like they're not knowledgeable. So we need to use language. Language should be used to further communication and understanding, but not to impress, intimidate, or overpower the client. As I said before, we must maintain a professional tone. Tone alters the impact of communication. And sometimes it's even stronger when it's dependent on your particular position. So as an assistant director or a director, you have to remember that you have a higher level position in the program, and if somebody is coming in to express either a complaint or an issue that's happening within the program, the way we speak also is coupled with the position that we have. Also, do not engage in personal exchanges or disclosures. And we've talked about that in past ethics training, that self-disclosure is really not as effective as it would be by just talking about what issues are at hand. And those personal exchanges can also blur boundaries. We also want to avoid verbal abuse, rationalized as therapeutic confrontation. Again, in the past, and as I talked about, we have changed a lot in our field. There was a much more stronger confrontational approach with some therapeutic settings that was an attempt to help the patient surrender. And what we've learned is that isn't necessarily effective, and that it's important that we have to speak firmly to a patient to set either structure, rules, guidelines, or boundaries. However, it should be done with therapeutic purposes and with uncompromising respect for the client. Also, the use of profanity is not acceptable. Using profanity, because it's consistent with what the patient is using, only reinforces the propriety of aggressive or juvenile utterances. It also sacrifices the professional's authority as a role model. So again, you're blurring the vision by utilizing it. You don't necessarily know culturally how that is interpreted. It's not professional. So there's a lot of reasons why we do not need to utilize profanity in order to get to or try to make a difference or impact our clients. We need to use language that's appropriate for the type of treatment being practiced, and it should be culturally competent. So there are some important considerations when we're utilizing person-centered language. First of all, the language is used neither stigmatizing or objectifying. So what do I mean by that? And it's kind of like what I talked about in the beginning with the title. We don't want to call the person a drug addict or a schizophrenic. We don't want to use their disease to identify them. What we want to be able to say is there is a person with schizophrenia, a person with addiction, or with a substance use disorder. So that is the person first, and then the disease is second. And so that's what I'm talking about when I talk about utilizing language as a stigmatizing factor. The language used is also empowering, avoiding the eliciting of pity or sympathy. So we don't want to use language that puts the patient in the victim role and reinforces negative stereotypes. And we've heard people say, well, he's just a dope fiend. What can we expect? Those are the kinds of things that maybe are even said in the hallways and are picked up by our patients between two colleagues. So it might not be that you're directly communicating with an individual, but that you're communicating with a colleague and it's picked up by a patient, and that lets them know that you're utilizing those negative stereotypes and making assumptions about individuals with substance use disorders. We want to be mindful of using words such as hope and recovery, and they should be used frequently not only in your verbal communication, but in the documentation and delivery of services that you provide. Providers attempt to interpret perceived deficits within strengths and resilience framework. This will allow for the individual to identify less with the limitations of their disorders. So we want to keep it strength-based. We want to be able to help the patient see what strengths they have so that they can move forward in their recovery utilizing those versus what they can't do. And so that's really important when we're in those individual counseling sessions and also treatment planning sessions. We also want to use diagnostic labels such as catch-alls. And my favorite one, and when I first came into the field over 35 years ago, is the use of the word borderline. And I didn't know what it meant then, but I knew that when a behavior would happen with a patient, everyone says, oh, they're borderline. Oh, they're borderline. What can we expect? So those diagnostic labels really don't help an individual, and it doesn't even help the staff understand what's going on for the patient. So as a young staff person at that time, I wasn't really certain, and since everybody was freely using the word, I was hesitant to ask. So it's very important that we begin to talk about if there's behavior issues with our patients, they're the person first with behavior issues that might be described more exact than to put them in a diagnostic category. And that also is good in terms of teaching those newer counselors also how to communicate appropriately with our clients. Now we have the power of language. And I have in the references for you a great attachment, and it's called "The Glass is Half Empty, the Glass is Half Full." And so here is a little bit of what it has here. And if you see on the left side of the screen here, we have the deficit-based language. And on the right side, you have the strengths-based, recovery-oriented alternative. I left these blank because this presentation was also done in person, and I encourage you to print this and utilize it to provide more reinforcement for your staff, but giving them an opportunity to come up with some ways we can better describe the individual rather than using these deficit-based language. And you've heard them all: a schizophrenic, a borderline, an addict, a junkie, the frequent flyer, the entitled, the helpless, the hopeless, and the grandiose. So what kind of strength-based language can we use? Let's take, for example, entitled. We might want to use aware of one's rights versus entitled. If we're looking at helpless, we might want to say unaware of their capabilities. Instead of using the word weaknesses, we could talk about barriers or challenges to their recovery. And in the case of schizophrenic and a borderline, as we talked about before, we would say a person who is diagnosed with schizophrenia and who experiences the following behaviors. So that kind of gives you an idea. This is an activity that you can do with your staff. If you take a look at the references in this presentation, you'll be able to pull up this document and do some further reinforcement with your staff utilizing this exercise. We wanted to also include for you, along with language, is person-centered planning. And person-centered planning is really at the forefront of our field right now. Those of you who are applying for 820 licenses will be challenged in your application and in your policies and procedures to demonstrate how you are doing person-centered planning in your new program. So I wanted to spend a little bit of time talking about that as you begin to embark on a new level of residential programming. We want to remember that person-centered treatment plans are holistic, so they're inclusive of what the person needs. They're highly individualized, and they identify positive outcomes based on the client's strengths and available supports. And so what do I mean by that? We have to move away from the same goals and objectives that we have, that we cut and paste and slide into our treatment plans. We need to ask the patient. The patient now becomes the expert at their plan, and they can often tell you what they need and what they didn't get, which led to their relapse and why they're back in treatment. So it's really important to begin to hear from the patient in terms of what they need and develop that plan according to that, so that it doesn't look like everybody else's treatment plan in the program. Rather than focusing on symptom relief, person-centered planning, and unifying vision, is for providers to collaborate with clients to develop customized plans that identify life goals and potential barriers. So we want to take a look at what are you collaborating on with the patient. As we talked about in the beginning, that therapeutic alliance, those foundations that we need, empathy, unconditional positive regard, and congruence. How are we utilizing those foundations to begin to customize these plans for our patients? Also, person-centered planning, a recovery-oriented practice, is designed to promote service engagement. We want to increase the client's self-determination during treatment. If they've had a vested interest in the development of their treatment plan and the goals that are on there, then they're going to have a vested interest in the groups that they're being exposed to, that the conversations that we have with others and those milieu-type therapies. It's really important because they see a purpose, because it's about what they wrote, what they need in order to make that next step. So we're moving away from the cookie-cutter approach to providing groups and programming. We're beginning to develop programs that are self-selected by the patient, that the patient has requested that they would like, and that increases engagement and increases the likelihood of successful recovery. It also recognizes the range of interventions and contributors. So who are they? And we go back to family and natural supports. If we're including the family, what kind of things need to happen? We have to hear it from the patient. What struggles has he or she had with the family members? And natural supports that it can be out there in the community. Who are we able to use? Who can we identify? Is it the sponsor or individuals in self-help? Is it the landlord? You might have a landlord who is a good supporter to that individual. It can be your priest or your pastor. Those are all necessary supports that we use in order to develop the appropriate interventions. And depending on how independent the individual is, you might even have some independent exercises for the individual so that they can come back and feel like they accomplished something. The more they accomplish, the more that will solidify the person's skills and abilities as they move in their recovery. Values, community inclusion, and desired outcome of supporting the dignity of risk-taking and the right to failure. And when I say the right to failure in this opiate epidemic, the failure has to be something that is easily able to be learned. We need to really take a look at why we're asking someone to leave our program, because we need to be able to find that spot where we can teach somebody about their recovery and the behaviors that lead to relapse, as well as the behaviors that teach them to cope and move on with their recovery. So when I say right to failure, I don't mean throw somebody out, because in today's world, people die when they leave our treatment programs. Motivational interviewing with the stages of change framework. And I often tell individuals during our multidisciplinary team meeting that our program is set up for the person who is active and ready to make changes. Most of the individuals that come into the program are still ambivalent. And so we want to be able to establish programming, establish interventions, establish our communication to help them move from that ambivalent about treatment to a solid connection and engagement to treatment. And we can do that with wellness recovery action plans. This also is a SAMHSA approved approach to helping the individual begin to take a look at those problem behaviors, problem symptoms that keep them from either relapsing or mental health symptoms that might result in hospitalizations. The Wellness Recovery Plan is a structured plan. It's been developed by Mary Ann Copeland. And if you take a look on the internet, you should be able to find that. And that's an excellent mechanism to help individuals begin to establish that recovery support within themselves as they move forward in their recovery. And a commitment to build a strong therapeutic alliance, support-centered, person-centered planning. Absolutely, and that's at the crux of the work that we do, is establishing that therapeutic alliance. If we're not doing person-centered planning, we end up getting a lack of engagement. We talk about, on an administrative level, how many individuals are actually engaging in treatment, how many are walking out the door within the first 7 days. That lack of engagement to treatment can be a challenge. And because we haven't done that level of person-centered care in the past, that we kind of dictated treatment, we told patients they can't be driving their own bus, that we know better, that has allowed them to think about our treatment system with a lack of trust. They have poor alliance with providers. They often say, I'm not going to this provider because, they threw me out and they didn't hear what I had to say. Also, providers not listening to their needs and inadequate opportunities to make decisions and collaborate in treatment. So difficulties should be met with collaboration, hearing both sides, and coming up with a win-win situation. And what we're all looking for is better outcomes, and as we move into value-based payments, better outcomes is critical. And so studies have found that person-centered planning was associated with greater engagement in services, which means a decrease in no-shows, a decrease in AMAs, and higher rates of medication adherence. And when our patients are adherent to their medications, they're oftentimes stronger in terms of dealing with some of those urges and cravings and that need to use, which can bring them back in terms of relapse. So here I have for you kind of a pictorial view of integrated care and person-centered care. Because integrated care, as I said before, is the way we're going. We're looking at mental health, we're looking at medical, and we're looking at the substance use disorder, and then we're looking to provide care that's empowered by our patients or our clients. So we have to take in the needs and views of the person that we're supporting. We also have to work with family members, as I've said before, provide care and support, which is high quality, evidence-based, supporting relationships between the carer and the person needing support. We also want to promote independence. We want people to move and get on their way and integrate into the community. We as providers must also be reliable and flexible so that we're taking care of individual needs and not being so rigid around rules that oftentimes push our patients away. And we need to ultimately communicate effectively with the person who's receiving support and their family and carers. As I talked about in the goals, we have this point where we identify SNAPs. And for those programs, again, transitioning with 820 licenses, SNAPs is an important aspect of your treatment planning. It's also utilized by accrediting organizations such as CARF and also JACO. SNAP is really to ensure that the person's receiving treatment is seen as individual with specific characteristics of need, and two, that they're engaged in the treatment process. So we're going to go through the strengths, needs, abilities, and preferences. First of all, the strengths. And oftentimes when we're asking our patients, what are your strengths? They are quiet. They don't necessarily know. They've been not having it good either out in the community or with their family members. They've been out on the streets struggling with a substance use disorder, maybe a mental health disorder. So the strengths are really what their assets are, what their resources are, and their natural positives. What is it that we can use to help them get their personal goals? And their strengths may be that they're stubborn and that they work hard. And so we want to be able to use those two characteristics, let's say, in terms of how we develop the treatment plan. Needs is what the individual, the person needs. These are your liabilities, your weaknesses, your essentials for living a productive and healthy life, and the assistance to achieve and maintain recovery. So what is it that the patient is challenged with? How might we help them get past those needs and utilizing the strengths to do that? Abilities, these are learned. So that's something that's a little bit different than strengths. Strengths are something we have. Abilities are something that we learned. So what is the person good at? What are their skills? What are their aptitudes? They might be bilingual. And so that that skill may get them somewhere in terms of their vocational aspirations. So we want to take a look at those skills, abilities, talents that our patients have in terms of developing those goals that they have for themselves. And preferences, which is something that we're not necessarily looking at all the time, as it says in the last statement here. This is the element that's least understood and left blank. But what does the person prefer? And for an example with that, I work with the ATCs in getting individuals placed in our programs through the family advocates. And oftentimes the family advocates will be telling me a little bit about the individual. And so each one of our ATCs has a different personality, different strengths that they have. And we try to do that match. We try to find something that the patient would prefer versus, well, I'm going to send you to this program because it's the closest. So we want to take a look at what does the patient prefer. Does the person prefer a rural setting versus a city setting? So these are the things when we're doing discharge planning that we want to take a look at. All of our programs across the state have personalities, and we want to make sure that the patient has expressed what they need to make it successful. So the benefits of SNAP has the ability to initiate the development of the treatment plan and the discharge plan. If documented appropriately, SNAP can give you a snapshot of the person and how they will do in treatment, the personality traits of the client, and the area of concern to work on throughout treatment. And so that, again, has to be very individualized as well. In summary, around SNAPs, we want you to get excited about raising the standards in your program. We want you to develop individualized treatment protocols and discharge plans for each person, ensuring that your client receives the best care possible, and those discharge plans need to include those preferences. Remember, they will trust you and your program with their life, and they deserve someone to take the time to get to know them, understand them, and treat them. And if you think about the parallel process, we all want supervisors that know us, that understand us, and that treat us with respect. Our patients want the same thing from treatment. And they'll be there. They'll be there and they will do the work that they need to do. And it's our duty to give them all the tools for a successful and rewarding recovery. I'd like to talk about the different ethical codes and patient rights that we have within OASAS, the Justice Center, and particularly the professionals that carry credentials such as the CASACs and the nurses. But we're going to start first with our patient rights, and this is through our regulations on the 815 regulations. And it addresses person-centeredness here. And these 2 points are to receive services that are responsive to individual needs in accord with an individualized treatment/recovery plan with the patient that helps develop and periodically update. So right then and there, you're seeing that a patient has a right to an individualized plan. Second is they have a right to receive services from a provider who's competent, who's respectful of patient dignity and personal integrity, and in sufficient numbers to deliver the needed services consistent with the requirements of the provider's operating certificate. So it's important that we provide those competent and respectful services, competent and respectful language. In the CASAC Canon of Ethics, there's a few points here as well that address person-centered therapy and approaches. We must not knowingly engage in behavior that is harassing or demeaning, including but not limited to sexual harassment. We need to remember individuals are different. We need to be culturally competent in dealing with the LGBT population. It's important that we get the education, that we understand that different populations may find things that are demeaning and hurtful. Also, we need to treat our colleagues and other professionals with respect, courtesy, and fairness. And we need to cooperate in order to serve the best interests of our patients or clients. And when I say that, I've talked about the fact that sometimes our communication in our hallways or elevator is not that of person-centered language. And the way we treat each other is something that the patient watches or that the clients watch in treatment. So that's also a reflection on the program and the values of the organization. We must respect the integrity and protect the welfare of the person or group with whom a counselor is working. And that's important. I can remember one instance in the Justice Center incidents is an individual was falling asleep in group. And that happens, one, because sometimes we don't sleep well. Sometimes we're on medications that cause some drowsiness. Sometimes it is a way to resist treatment. But the counselor went up to the chair and kicked the chair so that it had enough give to it. And the person was awakened very startlingly. So that's a form of communication. That's a form of disrespect. It's a form of the counselor being angry with the patient and expressing it in a way that, one, embarrassed him or her in the group and was not in the best interest of the person. We might want to find out why that person's sleeping. There could be a lot of different reasons. And if it is resistance, then there's an intervention for that. But kicking the chair doesn't help that. Also, we must notify appropriate authorities, including employers and OASAS, when they have direct knowledge of a colleague's impairment or misconduct which interferes with treatment effectiveness and potentially places patients and others at risk. So, as we've talked about in past trainings, we've talked about our staff sometimes not well themselves. They all have personal lives. They might be depressed. They might be anxious. Also, they might be under a lot of stress at work, and they communicate it in a way that's hurtful to others as having difficulty coping with their own personal stressors. So if you're seeing that, it's important to remind yourself that you're all mandated reporters, and not letting that go is being hurtful to our patients, hurtful to the person engaging in that behavior, and hurtful to the program. The ANA, or the Association of Nurses, the American Association of Nurses Code of Ethics, also tells us that the nurse practices with compassion and respect for the inherent dignity, worth, and unique attributes of every person. And you have to remember, our clients are not feeling good for quite a while. So oftentimes they will come to the nurse's station. They might be insistent on medications because they don't feel well. But we need to remember and go back to talking to them about how they're feeling, what is not good, what we can do, what we can't do at the moment, and trying to understand how they're feeling at the moment that they're with you. The Justice Center has a code of conduct, and that code of conduct is located on the website. It was revised January 2016, and the requirement is for all licensed programs all OASAS license programs is that we review and sign that attestation every single solitary year. When OASAS comes in and does your program review, it's important to remember that they're going to ask for that file. They're going to look for it happening every year. So please take a look and use that time to not just pass out that paper and have people sign it and throw it in the personnel file, but use that time to provide an update of training and what it really means for them to sign the code of conduct. Because as we've said before, just having the code doesn't necessarily mean that people are going to not break those code of ethics. So the first thing, which is interesting on the Justice Center Code of Conduct, is having a person-centered approach. So it says specifically, my primary duty is to the people who receive supports and services from this organization. I acknowledge that each person of suitable age must have an opportunity to direct his or her own life, honoring, where consistent with agency policy, their right to assume risk in a safe manner, and recognizing that each person's potential for lifelong learning and growth. I understand that my job will require flexibility, creativity, commitment, and whenever consistent with agency policy, I will work to support the individual's preferences and interests. So as you can see here, the Justice Center has lifted a lot of the language from the person-centered approach. And so it is the expectation that each and every person who works within a licensed program at OASAS adheres to this type of therapy. Other highlights from the Code of Ethics that really bring about and support person-centered therapy or approaches is to promote the physical, emotional, and personal well-being of patients. We also want to be respectful, dignity, and choice, recognizing individuality of each patient and honoring their choices and preferences whenever possible. And we also want to have integrity, responsibility, professional competency, and we need to remember to continue our education and seek supervision. And supervision, as you know, is one of those year in ethics trainings that I will remind you of if you haven't taken it yet. Supervision is critical in helping us maintain our code of ethics and treating our patients with dignity and respect. So in conclusion, person-centered care and communication are vital to the ethical healthcare. And person-centered care is reflected in a number of key ethical codes, as you saw here today, guidelines and standards that strongly support the ethical consensus that a healthcare organization must take steps to foster and promote patient-centered care. So this is a requirement. It isn't a therapy that we just get to select. It is something that can work collaboratively with other therapeutic approaches, and it is what we're going to expect to see as some of the residential programs move to the 820 licensure. So that really concludes the training today. I do have the list of references, as you can see here. The book, which is the second one here, Preventing Boundary Violations in Clinical Practice, is an excellent book to have. Very reasonable. I believe it's $40 on the internet, and that's a great book to have as a reference book at your program. And it's important to take a look at the others, and I want to say, I thought I had on here, and maybe I did not. I thought I had here the the glass is half empty, the glass is half full, and I don't see it. So if you want to get a copy of that, I can send that to you. You have my email here. I've also heard from a lot of you out there in the programs. I'm very happy to help whenever I can. I will certainly write you back and give you any kind of reference materials you might need to establish your own ethical trainings within your programs. So please feel free to email me and I will get you that particular attachment. So thank you very much.
Thank you, Maria, for your time and for lending us your expertise today. As always, we appreciate your feedback. After you finish watching this presentation, you can take a test in our test portal for credentialing hours if you wish, and then you'll be directed to a survey. If you wouldn't mind completing that survey, we would really appreciate it because we do use it for future Learning Thursdays presentations. Thank you for joining us today. Have a wonderful day.